He was 4 years old when his mother found him sitting calmly on the kitchen floor, chewing on his own fingertips. He had bitten the skin away from 2 of them. Blood was running down his wrist. He was not crying. He was not even flinching. He was looking at her with the same untroubled expression he had every other morning. As if nothing at all was wrong. It was not the first time. By the age of 2, he had already lost the tip of his tongue. He had chewed through it during teething and had felt nothing to make him stop. By the age of 3, he had walked on a fractured ankle for almost a week before anyone noticed the swelling. By the age of 5, his medical record made for grim reading. Burns on the palms of both hands from a stove. Multiple unset fractures in his legs. A partially detached retina from an unnoticed eye injury, and the early stages of a bone infection that had been quietly eating through his femur for months. His parents had not been negligent. They had watched him every day. The problem was that the boy himself had given them no signal. No cry. No wince. No reflex. No warning. He had been born without the ability to feel pain at all. Nobody could have predicted what came next. Because his doctors knew this condition. They had read about it. None of them had ever seen a patient survive long with it. The condition has a proper name. Congenital insensitivity to pain. CIP for short. It is one of the rarest and most dangerous genetic disorders ever described. Estimates from clinical literature suggest only a few hundred well-documented cases worldwide. Patients are usually scattered across isolated families and communities, often in regions where consanguineous marriage is more common, and it has taught medicine one of the most counterintuitive lessons in the entire history of human biology. Pain is not a defect of the body. It is one of its most essential, most life-saving inventions. The disorder has been recognized in the medical literature since the early 20th century. The first detailed clinical description in the English language is credited to American physician George Van Ness Dearborn. In 1932, he wrote about a patient with what he called congenital purinalgesia. For decades after Dearborn's description, doctors knew that some children were being born without pain perception. They knew the consequences could be severe. They did not know why. The disease appeared to run in families. It seemed to be present from birth. The patients had normal intelligence. Their sense of touch, in most cases, was intact. They could feel pressure. They could feel temperature in a vague, non-painful way. They could feel the difference between rough and smooth. What they could not feel was pain. A pin pressed into the skin felt like pressure. A hand placed on a hot stove felt like contact. A bone breaking felt, at most, like a strange shift inside the body. There was no signal of injury. No automatic withdrawal. No instinct to protect the damaged area. The medical histories of CIP patients read almost like horror stories. Infants chew their tongues, their lips, and their fingertips during teething, sometimes inflicting severe damage before parents realize what is happening. Toddlers learning to walk fall hundreds of times like every other toddler. But they do not learn to avoid the floor in the same way. They do not learn that a hard fall hurts. Because for them it does not. As a result, they fall repeatedly on the same body parts. Fracturing bones. Dislocating joints. Developing chronic deformities. Burns are common. CIP children touch hot food. Hot stoves. Hot radiators. Scalding bath water. They do not pull away. Their skin scars and blisters silently. Eye injuries are particularly dangerous. The cornea relies heavily on the protective reflex of pain to prevent damage from foreign objects. CIP patients can scratch their corneas repeatedly without realizing it. Many lose vision in one or both eyes by adulthood. Joint damage is another characteristic complication. Normal children spare their joints by avoiding positions that hurt. CIP children do not. Their hips, knees, and ankles wear down at accelerated rates. Many develop what is called Charcot joint, a severe degenerative arthritis caused by repetitive use of an injured joint that the patient does not realize is injured. By their teens or 20s, many CIP patients require multiple orthopedic surgeries simply to remain mobile. Internal injuries are the most dangerous. A CIP patient with acute appendicitis does not feel the classic crippling pain that drives most people to the emergency room. They feel mild discomfort, perhaps a sense of pressure. Often not until the appendix has already burst. Heart attacks are notoriously difficult to recognize in CIP patients because the diagnostic gold standard symptom, crushing chest pain, is simply absent. Some CIP patients have died from preventable conditions because they did not know there was anything wrong until the damage was beyond repair. We are halfway through this case. And the worst part has not happened yet. For most of the 20th century, doctors had no way to explain the condition at the molecular level. They could see it. They could describe it. They could not name what was wrong. The breakthrough came in the early 2000s. Researchers focused on several extended families with multiple CIP patients, particularly in northern Pakistan, where consanguineous marriages had concentrated the condition within identifiable bloodlines. Detailed genetic analysis was performed on every affected individual they could find. In 2006, a research team at the University of Cambridge published a landmark paper. The team was led by geneticist Geoffrey Woods. The journal was Nature. They identified a series of mutations in a single gene. The gene was called SCN9A. SCN9A encodes a sodium channel called Nav1.7. Sodium channels are tiny protein structures embedded in the membranes of nerve cells. When a nerve is stimulated, sodium channels open. Sodium ions rush into the cell. This rush changes the electrical state of the nerve and propagates a signal down its length. Nav1.7 is the specific sodium channel responsible for transmitting pain signals from peripheral pain-sensing nerves, called nociceptors, into the spinal cord. From there, the signal travels to the brain. Without functional Nav1.7 channels, pain signals never make it past the first step. The nociceptors detect a noxious stimulus. They try to send the signal. The signal is not propagated. The brain receives no information about the injury. Other sensations, transmitted by different nerves with different channels, remain intact. The patient feels pressure and temperature normally, but pain does not exist for them. The answer was, in a way, ridiculously simple. One gene. One channel. One missing piece of hardware. And the entire experience of pain disappears from a human life. The identification of SCN9A mutations as the cause of most CIP cases was a profound moment in pain neuroscience. It demonstrated for the first time, with absolute clarity, that pain in humans depends on a single, specific molecular pathway. Knock out that one channel, and the entire pain experience disappears. This finding had immediate implications for pharmacology. If a drug could selectively block Nav1.7 channels, it might function as an ideal painkiller. More powerful than opioids, and without the addiction, tolerance, and overdose risks that have caused the modern opioid crisis. Pharmaceutical companies around the world began racing to develop Nav1.7 blockers. As of the most recent published research, none have yet achieved unambiguous clinical success. Designing a drug that selectively targets Nav1.7 has proven extraordinarily difficult. The human body has 8 other sodium channels. Interfering with any of them causes serious side effects. But the search continues. Many researchers consider it one of the most important targets in modern pain medicine. The CIP patients themselves have suffered profoundly. But they have inadvertently provided medicine with a roadmap, a path toward potentially saving millions of others from chronic pain. Despite the genetic insight, life expectancy for CIP patients remains shortened. Mortality data for CIP is difficult to compile because the condition is so rare and so scattered. But multiple clinical reviews suggest that a substantial fraction of patients do not survive past early adulthood. Causes of premature death include unrecognized internal injuries, untreated infections, multi-system trauma from accidents that produce no warning pain, and complications of repeated surgeries. Patients who survive into middle age generally do so because of intensive medical management. They learn, intellectually, that they must check their bodies daily. They must look at their skin for injuries they cannot feel. They must visit their dentists frequently to catch infections they would otherwise miss. They must monitor their temperature, their pulse, and their digestion as proxies for the warnings their nervous system cannot give them. They become, in effect, their own pain sensors, substituting cognitive vigilance for the automatic, reflexive protection that the rest of us never have to think about. It is exhausting. It is imperfect. It is the only option they have. The story of CIP turns the popular fantasy of painlessness completely on its head. Many people, at some point, have imagined what it would be like to feel no pain, to never suffer a headache, to never wince at a stubbed toe, to walk through life with the indifference of a stone. The reality, as documented in case after case by clinicians who have spent their careers caring for these patients, is the opposite of indifference. It is constant, low-grade hypervigilance. It is a body that does not protect itself. It is a brain that has never been informed that something has gone wrong, and so cannot mobilize the immune response, or the protective reflex, or the careful repositioning of a limb that the rest of us perform automatically thousands of times a day. Pain, in normal humans, is not a malfunction. It is a continuous monitoring system that keeps us alive by ringing an alarm bell every time something threatens the integrity of our tissues. CIP patients live without that alarm bell, and they pay a price for the silence that most of us, fortunate to feel every small ache and pain, never have to imagine. Next case, a man whose body began to slowly turn to stone from the inside out. His muscles, his ligaments, and his connective tissue gradually hardened into bone over the course of his life. By the end, a second skeleton growing inside his body had locked him in place. There was no cure. There was no surgery that could help him, and the genetic mutation responsible has been documented in fewer than 1,000 patients in the entire history of medicine.